Good day to all of you. I am Manidu Patiran from Sri Lanka, Chair of the Prevention Council of Asian Heart Society. And on behalf of the Prevention Council of Asian Heart Society, let me welcome all of you to the symposium on cardiovascular kidney metabolic health of the at the Asian Cardiovascular Clinical Research Seminar 2025. So, as the Prevention Council, we have been regularly participating in this biannual event of the Asian Cardiovascular Clinical Research Symposium. And today, I am joined here with by two deputy chairs of the Prevention Council, Dr. Yihon Sang from China and Dr. Koji Hasagawa from Japan. And to start the proceedings, let me invite Dr. Koji to introduce our first speaker for the symposium.
Thank you very much, Professor Ani. This is a very important symposium because cardiovascular system, kidney, and diabetes, dyslipidemia, all are combined in aging society. So we like to discuss the connection of the heart, vessel, kidney, and metabolic diseases. The first speaker is Dr. Jae Young Cho, is a board-certified cardiologist specializing in heart failure and heart transplantation. His interests include echo and valvular heart disease. His commitment to lifelong learning has led to multiple opportunities in teaching others and participating in clinical research. So, he's gonna speak about the importance of risk factor control for the prevention of heart failure. Dr. Jai, please.
Thank you, Dr. Hasegawa, for introduction. I'll share my slide. Can you see my slide well?
Yes, we can see that,
Yeah,
and we can
thank you.
hear you well. Yeah.
Yeah. So I'm honored to be here to present my talk. Actually, my talk is a little bit general. So for the cardio kidney metabolic disease and the prevention of heart failure, nothing to declare. So the cardio kidney metabolic condition, so we so-called CKM conditions, pose a high disease burden globally. Actually, CKD, the people with CKD is up to 850 million worldwide, and prevalence of CKD up to 11%. And in its early stages, there's low awareness of the disease. And the prevalence of type 2 DM is very high and rising across all regions. The patients more than 450 million. And also, the people with heart failure, there are 60 million patients worldwide, and also approximately 50% of people diagnosed with heart failure will die within 5 years of diagnosis, actually, even now. So there are unmet needs in heart failure, and this scarcity approved therapies for heart HFpEF. So it's very important. And CKM conditions frequently coexist because they are interconnected. For example, up to 40% of people with type 2 DM have CKD, and also 60% of people with CKD have CV disease, and 30 to 40% people with heart failure have CKD. So they're interconnected um, populations. Also, having one cardio or kidney or metabolic condition increase the risk of developing other CKM conditions. So because they share risk factors like dyslipidemia, old age, obesity, and so on. So it's very unique and interesting. The coexistence of type 2 DM and kidney disease associated with the increased mortality. It's from enhanced US population-based study. If there is a type 2 DM alone, the standardized 10-year cumulative incidence of mortality, 17.8%. But the type 2 DM, if the patient have type 2 DM albuminuria and eGFR less than 60, the excess mortality for people uh, goes up to 54.7%. The cardiovascular kidney metabolic syndrome is a systemic disorder characterized by pathophysiologic interactions among those metabolic risk factors and cardiovascular system, multi-organ dysfunction, and it causes high rates of adverse cardiovascular outcomes. So it defined as a overlap of axis between obesity, type 2 DM, chronic kidney disease, and also heart disease. So it causes premature morbidity and mortality. The stages of CKM syndrome uh, divided from stage 1, stage 0 to stage 4. If they have stage 0, there are no risk factors. And stage 1, they have overweight, obesity, or impaired glucose tolerance. And in stage 2, hypertension, metabolic syndrome, hypertriglyceridemia, type 2 DM, and CKD. And in stage 3, there are subclinical CVD in CKM syndrome, subclinical ASCVD, or subclinical heart failure. But in stage 4, there are overt clinical cardiovascular disease like coronary heart disease, heart failure, AFib, stroke, and peripheral artery disease. So those kind of multiple uncontrolled risk factors increases the risk of heart failure. It's like A1C more than 8, systolic BP more than 160, BMI more than 35. It's like this. We usually see the tips of iceberg, so-called heart failure stage 3C and stage D, but we should be aware of the stage A and B, and we have to intervene stage A or B very actively. There was an interesting study presented in the ACC this year, heart failure risk according to CKM stages. And they say that the CKM health is common in the US also, and but it remains uncertain whether CKM staging framework predicts cardiac remodeling or incident heart failure. They used the ERIC study, state PZ5, so 5,600 patients based on AHA CKM syndrome staging framework, and outcomes were LV remodeling and systolic diastolic function assessed by echocardiography. And research was CKM stage distribution. Their most frequent stage was stage 3, 44%, and the stage 4A, 32.6%, with no kidney failure, and stage 2, 20.4%. And higher CKM stages were associated with the higher risk of instant heart failure. So like in stage 2, 22.2 events per 100 person years, and stage 3, 63.0 events, and significant trend across stages, statistically significant. So the conclusion was higher CKM stages are strongly associated with adverse cardiac remodeling and increased heart failure risk. And also the same group from Denmark analyzed the Paragon HF study. Also in that HAPPEP study, the population has CKM conditions. All three conditions, almost 16% of patients have all three conditions, and more conditions with for the primary endpoints of CV deaths, total heart failure, hospitalization, and all-cause deaths. These primary endpoints increases, and also the endpoints itself as a secondary endpoint increases along the CKM conditions increases. And also echocardiographic measurement shows that like a E over E prime value indicating diastolic dysfunction, or LA volume index, or global longitudinal strain decrease, is associated with the CKM burden. Also, in CKM syndrome stages and outcomes, there are studies uh, conducted in Korea. These use the national health data. They used 877,000 people with the first health checkups and second health checkups. So they decided the stages in the first health checkups, and they used the second health checkup data, and then some people showed the decreased stages, 96,000, and usually most of them maintained in their stages, 647,000, and increased 134 people. But that adjusted event curves according to changes in CKM stage. If the CKM stage increases, the composite outcome increases significantly. The primary composite outcome was all-cause death, heart failure, hospitalization, and stroke, and MI. Also, the hospitalization for heart failure itself drive the difference in the between the groups. What do we do for the prevention of adverse heart failure outcomes? The ESC heart failure guidelines, Focus Update 2023, says that the patient with type 2 DM and CKD, SGLT2 inhibitors are recommended to reduce the risk of heart failure hospitalization or CV death. And finerenone is recommended to reduce the risk of heart failure hospitalization. Actually, the level of evidence comes from for the SGLT2 inhibitors, DAPA-CKD and EMPA-KIDNey, and these incorporated into meta-analysis, which was published in Lancet 2022. And for the finerenone, there were Fidelio-DKD and Figaro-DKD RCT, and those data pulled in the Fidelity study. So in the DAPA-CKD study, the cardiovascular deaths and heart failure hospitalization decreased the risk reduction 29% with the dapagliflozin. And EMPA-KIDNey, there is a not that significant statistically, but in the meta-analysis of those placebo-controlled trials, including those DAPA and EMPA, the diabetes patients showed 23% of risk reduction with SGLT2 inhibitors. And also the Fidelio-DKD and the Figaro-DKD and those kind of total number of patients summed in the Fidelity pooled analysis, the CV composite outcome, time to CV death, non-fatal MI, and non-fatal stroke, and heart failure hospitalization. The Fidelio-DKD showed a trend toward the lower heart failure hospitalization in finerenone group, but not that significantly, statistically significant. But in the Figaro-DKD, the heart failure hospitalization was primary composite outcome, and also it was statistically significant, reduced the hospitalization in finerenone group. And also in the Fidelity pooled analysis, the primary outcome was achieved significantly, and also the heart failure hospitalization itself was significantly reduced with finerenone. Actually, the glucagon-like peptide 1, GLP-1 receptor agonist is also very hot these days. But the major GLP-1 receptor agonist cardiovascular outcome trials showed heart failure hospitalization reduction only in the Amplitude O study, which used epiglutide. So we have to have more studies about this GLP-1 receptor agonist, I think. So RAS blockers and SGLT2 inhibitors and non-steroidal MRAs like finerenone slows CKD progression and reduces heart failure risk with those many studies published to date. But also they say the CKM for the CKM disease, we have to use four pillars of GDMT, like RAS blockers, SGLT2 inhibitors, finerenone, and GLP-1 receptor agonist. Actually, AHA suggested the algorithm for the management of patients with CKM syndrome, stages 1 to 3, and for the stage 2, the hyper-TG, hypertension, and CKD, diabetes, there are medications and the treatment method that I mentioned earlier in this algorithm. So I want to uh, summary. We have to have a discussion, so I have to stop early. I would say the prevention of heart failure begins with modification of individual CKM status, and RAS inhibitors, SGLT2 inhibitors, and non-steroidal MRAs like finerenone have demonstrated heart failure preventive effects across CKM continuum. And but GLP-1 receptor agonists offer cardiovascular protection indeed, but their role in heart failure prevention remains to be clarified with further studies. So further studies are warranted in patients with more active and advanced CKM status. Thank you for your attention.
Thank you very much for your excellent work. Now, we need to consider heart failure as one of the systemic disease. We need to take care of the kidney diabetes, and also at the same time, we need to think about the prevention rather than treatment after the development of symptoms in patients with heart failure. That's very important message. Thank you very much for your lecture. And is there any comment or question from the audience? So one question is, in Korea, how much percentage MRA or HAT2 inhibitors are used in patients with mild CKD patient? Because the kidney specialist will take care of the kidney disease, maybe end-stage kidney disease like EGFR less than 15. On the other hand, cardiologist will take care only of the heart and often will not take care of the mild CKD like EGFR 40 or 50, but with proteinuria. And also diabetologist will take care of the blood glucose alone. So who do you think should take care of the prevention of heart failure in terms of treatment of CKD at earlier stages in clinical practice? Do you have any idea who? Well, most of the specialists only specialize in their own area. So who should take care of the mild CKD for the prevention of heart failure?
Yeah, actually, mild CKD patients are the cardiologist can neglect those kind of patients. I think. Actually, I'm not a nephrologist, so uh, but I heard from nephrologists that actually so far uh, their so the CKD progression they want to the reduce the CKD progression, but so far they had no actually medications treatment method. But now we have SGLT2 inhibitors and the finerenone, so they want to use those kind of drugs more actively than ever. And also, I think that the SGLT2 inhibitor we can prescribe for the patient with even in the milder stages of CKD. with diabetes mellitus, or just have if the patient have a heart failure with preserved ejection fraction, so increased uh, NT-proBNP. So those kind of patients, I would prescribe SGLT2 inhibitors more actively, I think.
Thank you. Dr. Camila, do you have any comment or
Yes,
question?
and thank you for very comprehensive lecture. I think because now when patients go to specialists like for cardiologist or the nephrologist, they go once they have the uh, either a CVD event or when they get the CKD. But the prevention part is very important. I think the best place to start is with the internal medicine physicians because they're the people who see people who just come with high blood pressure or just come with raised blood sugar or obesity at the beginning. So probably needs to start that the intervention should span all over the period, but we have to focus on and educate the physicians, the general physicians and the internists who are the people who see the patients early in the disease course so that they can take preventive measures to prevent them going into those complications of diabetes and hypertension and the obesity.
Thank you very much.
Thank you.
General is becomes more and more important. Yes, I agree. Thank you very much. Okay, thank you very much for a nice lecture and nice
Yeah,
discussion.
maybe, Toji, sorry.
Okay, yeah,
Maybe I want to add one more comments that
Okay.
because we're talking about nephrologists and I think there's still a big challenge for the management of diabetes patients to prevent heart failure. I mean, the endocrinologists still need to know the importance of this prevention of heart failure in patients with diabetes. I think the heart failure is underdiagnosis in patients with diabetes and either diabetes or kidney disease patients. I think the prevention, the prevalence of the HFpEF should be very high in this kind of patients. And yeah, and SGLT2, although cardiologist is very keen on this, but I don't think diabetics use it a lot. Most of patients still receive the insulin as the first line treatment, something like that. Yeah, just one more comment. Thank you.
Yeah, thank you very much. Yeah, overlaps area are very difficult but important. We need more advocacy. Thank you very much.
Yeah. So I would like to introduce
Yes.
our second speaker. So our second speaker is Professor Xin Zhou from Tianjin, and his topic is also very important, is adverse pregnancy outcomes and cardiovascular kidney metabolic syndrome. Professor Zhou is from the Tianjin Medical University General Hospital. He's a chief physician and has been, published 100 research papers in peer-reviewed international journals, and he also have some very important position in academic societies. So I know Professor Zhou have many, wonderful high-level publications. So welcome, Professor Zhou. Yeah.
Okay, thank you, Professor Sun. I will share my slides. Okay. Excuse me. Okay, sorry. I can't share, just put the share screen button. OK， 我可以听到，但是我看不到。我知道，然后后面出来一个 Microsoft 窗口，还有一个整个屏幕，我看 您现在能看到吗？您看，OK OK OK. Can you see the slides? Okay.
Yeah, you
Okay.
can see.
Okay, I'm so pleased to have this opportunity to talk about the very interesting topic concerning the adverse practice outcome and the CKM syndrome. I'm Dr. Zhou from Tianjin. I'm a cardiologist. I have no conflict of interest to declare. So my talk will focus on the following 5 parts. First, you know that in 2023, American Heart Association has published a very important announcement concerning the new definition of cardiovascular kidney metabolic syndrome. I think this syndrome is a comprehensive integration of multiple organ diseases, including obesity, diabetes mellitus, chronic kidney, and cardiovascular disease. And I think this novel conceptual framework will facilitate in the integration of a cardiologist enter nephrologists and also the physicians focusing on the metabolic disorders, so that it's a very important topic to share. And you know, currently the pathophysiology concerning the CKM syndrome focusing on the inflammation, oxidative stress, insulin resistance, and vascular dysfunction is they're connected together and propagate to their development of this syndrome from the no risk to the clustering of risk and to the finally overt clinical manifestations. And this slide has been showed by the previous speakers, and this showed that the 5 stages of CKD. The first stage is stage 1, often no risk factors. The stage 2 concerning their accumulation of excess and dysfunctional adipose tissue. And the stage 2 is characterized by the clustering of traditional risk factors for their cardiovascular disease, including hypertension, metabolic syndrome, and also the diabetes. And even for myself, you know, even I have 2 to 3 average working or activities each week. So I have hypertension. So I belongs to stage 2. I'm personally belongs to stage 2. And for the stage 3, and the patient may manifest subclinical CVD, and to the stage 4, the overt clinical manifestation, including ischemic heart disease, heart failure, and peripheral artery disease. Sometimes patient will suffer from atrial fibrillation and consequently ischemic stroke. And this study is very important because after publication of AHA statement, the paper published in JAMA stated that almost all the body adult, the study evaluated the US adults, and they found that each of us could be categorized into the following 5 stages. The stage 1 only accounts for 10%, and the stage 2 accounts for 1/4 of the total adult population, and the stage 2, 50%. And we can see that for the advanced stage, especially the stage 3 and the stage 4, on about 15 states, so that this definition has already incorporated all the adults of our society, so that each of us could have some kind of involvement in this new concept of definition. And we'll talk about evidence from general population, so that this study is important because it's based on Chinese population, and this based on the Kailan cohort, which is located in northern China, involving almost 100,000 patients with a follow-up of 15 years. And this study showed that as the stage from stage 1 to 4 increase, there was sharp increase in the stage 3 and stage 4 for the all-cause mortality. And this study is also based on China. It's a nationwide larger study based on almost 10 years of follow-up. Interesting, this study focusing on their cardiovascular risk compared with the previous one. They're using competing risk models and they find that the suboptimal healthy factors contribute to large populational attributable fraction to CV risk in early stage. But, the suboptimal healthy behavior exhibit a larger contribution to the advanced stage. So that this study indicates that even for patients with advanced stage, healthy lifestyle may have a beneficial role to stop or even regress the disease progression. So that is very important for their prevention of this very important disease entity. And this study is based on Eric study. This study used the prevention equation and calculated the risk for the future CKM syndrome. They categorized the patient into four different categories. And this study first demonstrated that as the risk increase, the increased risk of dementia will increase dramatically, so that the following four study, which focusing on all-cause mortality, cardiovascular mortality, and even the dementia, highlight the importance of CKM in the chronic, very important disease for the human society. And I will talk about this study because today I will talk about the adverse practice outcome. So this is very important because this paper published in ATVB this year and found that women compared with men exhibit a lower prevalence of CKD3, but we can see from this table that at early each stage 1, 2, 3 to 4, for every stage, the women have a higher all-cause mortality compared with the male compartment. So that this study indicates that the women should have an enhancing risk factor to further exacerbate the clinical presentation and their long-term prognosis. So we'll talk about the evidence from pregnant population. This figure is very important because it tells us about how they are cardiovascular metabolic disorder exposure during the early stage of life or during the pregnancy and the future cardiovascular cardiometabolic risk, so that a well-known risk factor for future cardiovascular disease in women is the occurrence of preeclampsia. This disease is a placenta-derived disease. It's characterized by hypertension, proteinuria, seen as symptom, and other symptoms involving multi-organs. For the mother, they will develop hypertension. For the baby will bear with limited, small body weight, especially for the small for gestational age, short for SG birth. So that after birth, both the mother and the baby have a higher risk for their future cardiovascular and metabolic disease. Currently, if we could identify the patient at the later life, so that we can see the trajectory of future disease will only be reduced by this little. And if we can identify earlier, that we could reduce their future risk. So that for our clinical practice, the patient who suffer from hypertensive disorder in pregnancy, after 42 days, all the patients will discharge from our community, and no one or no physicians will tell them you are at high risk of future disease. So that this is the current knowledge gap in our clinical practice. And then maybe 10 years later or 20 years later, the patient may have overt clinical presentation, so that it's too late for them to prevent the future cardiovascular disease and mortality. So that current evidence indicates that the occurrence of preeclampsia increase the risk of coronary heart disease, heart failure, aortic stenosis by 2 to 3-fold, and also increase the risk of mitral regurgitation by about 4-fold. And obviously, that because preeclampsia is characterized by the appearance of proteinuria during the half-life or the second half of the pregnancy, so that it's natural that the patient who have preeclampsia usually have a worsened risk of developing future chronic kidney disease. And this paper is important because it summarized 41 cohort, including almost 3,000 preeclampsia patients, and compared with normal intensive controls. This study found that compared with control, the patient with preeclampsia have increased the postpartum blood pressure level, the body mass index, the total cholesterol level, LDL, triglyceride level, or elevated glucose level. So that this study indicates that preeclampsia is very important risk factor for the future development of multiple risk factors for the CKM syndrome. So that this JACC review published in 2022, focusing on the female-specific risk factors that enhancing the future cardiometabolic risk. You can see that from this table that for pregnant women, that their enhancing risk factors including preeclampsia, gestational hypertension, gestational diabetes, and preterm birth, and even we mentioned before the delivery of small for gestational age babies. So that all these components are key elements of adverse pregnancy outcome. They are should be treated as a female-specific risk-enhancing factor for the development of future CKM syndrome. And you know that gestational hypertension is very important because they increase risk of postpartum diabetes mellitus. And in general, GDM have a higher risk of almost one-fold increase. But this study found that the GDM patient may be heterogeneous because only the patient who are treated with the insulin during the pregnancy have increased the future risk. The patient who diagnosed with diabetes mellitus, if they are not treated by insulin, their future risk is not increased. So this article indicates that the gestational diabetes patient may be heterogeneous, so that we should treat them individually. And as to the potential mechanism concerning the adverse pregnancy outcome in CKM, the current focusing may be focus on the RAS inhibition. Although RAS, we know that is very low risk factors for the development of obesity, hypertension, but why they play a key role during pregnancy? Because we know that during pregnancy, there is a dramatic increase in plasma level, almost a 50% increase during the late pregnancy. So that, RAS is very important for their sodium retention and fluid overload. Because if patients do not have adequate sodium retention and fluid retention, their plasma level will not be increased, will not be adequate to support their baby's growth. So that for the patient who have overt or exaggerated sodium retention or fluid retention, the patient may suffer from edema or hypertension. But for some kind of patient with preeclampsia, the physiology underlying their pathogenesis involves inadequate sodium retention and inadequate fluid retention. So that abnormalities in RAS inhibition or RAS activity may be a very important pathophysiology underlying their APO and CKM. And next we'll talk about our current work. Currently, we have very useful database to access. And the first week concerning, we have access to Tianjin, our local Tianjin General Hospital, our hospital data. And also we have our collaboration from Southern China, Guangzhou cohort. We combine the two cohort together. We can expand the sample size. We use the maternal identification for many important information from the electronic health records. And we extracted the diagnosis, and especially for the antepartum care, for the blood pressure change, body weight change, glucose change, and also other biochemical assays. And also we have information concerning the feature outcomes. By combining it together, we did a very interesting work. During pregnancy, hypertension, we know that is associated with the occurrence of SG baby. Elevated diabetes mellitus, especially GDM patient, elevated glucose level is associated with a large for gestational age. But during pregnancy, hypertension and GDM often coexisted. So there is a very important interconnection between glucose level and blood pressure level. We found that by combining the two databases together, there is a very interesting correlation by the contour regression showing that if the patient have a higher BP level, their increase of their blood glucose level will increase dramatically, which indicates that some of the patients for glucose level may be driven by the elevation in blood pressure level. So we found that if we treated blood pressure level as a first priority to reduce blood level, their SG risk will be reduced. And further, then we followed by the not aggressive, moderate reduction of glucose level, and their total pregnancy outcome will be reduced. But if we, according to the guideline that treat the blood pressure level and the glucose level independently, not concerning together, the aggressive reduction of glucose level will increase the risk of SG patient. So that our work indicates there is a co-management for BP level and glucose level during pregnancy. And we also have access to our local large database. This is called Tianjin Health and Medical Data Platform. Tianjin is one of the 32 province-wide administrative unit in China has a total population of 13.9 million. And we currently combined the electronic health together, hosting all our tertiary hospital and the majority of our secondary hospital, and especially almost 100% of the community healthcare. Combining the three-level healthcare system, we can track the patient hospitalization and their outcome, because we also link the mortality data together. And from 2009 to the 2022, a total of 1.2 million pregnancies has been identified during the Tianjin Health Medical Data Platform. And by using the strict criteria, we also use the ICD code for the hypertensive disorder and gestational hypertension to identify, to try to examine the association with the future cardiovascular disease. And currently, we have a median follow-up of about 10 years. So from this figure, we can see that after identifying an eligible patient, almost 0.8 million people, we found that the key component of CKM syndrome, hypertension, coronary heart disease, diabetes, stroke, heart failure, and CKD, we also enjoyed another component, fatty acid. We found that for the patient with the preeclampsia, their association with all the 8 components of CKM and consistently increased. But for GDM patient, we can see only some, not all of them, but the hypertension, for the coronary heart disease, and the patient with diabetes mellitus increased, but not all of them increased together. So that this clearly indicates that GDM patient should be treated as a heterogeneous population. To further identify the potential mechanism for the GDM-related heterogeneous prognosis, we're focusing our study on the almost 100,000 patients with GDM diagnosis. We used the latent classical analysis. We identified the 4 patterns of GDM patient. The first one is characterized by cesarean surgery dominant, all the patients underwent cesarean surgery. And the second pattern is SG dominant, all the patients identified with occurrence of SG. This is a class 3. Class 3, we treated it as low risk because we can see that the APO risk in this group is dramatically low compared with other group. And the fourth class, this class is characterized by almost 1% of preterm births, and also high risk of SG, LG, and cesarean surgery, and also the relatively high proportion of PE patients. So that when we treated at the class 3 as a reference, we found that for the class 4, the patient with preterm birth of a GDM patient, almost all the 8 components of CKM increased dramatically and consistently, but for the other classes, their increase not consistent. So this work indicates that we should further stratify the GDM patient according to the APO clustering to identify who is a high risk for future CKM and who is relatively low risk. I think this is important for their future risk stratification. And another important topic is body weight retention during pregnancy. You know that we call this postpartum weight retention because for each woman with pregnancy, almost 10 kilogram increase for the body weight. But after 1 year postpartum, it reported that about 20% of women still maintain a body weight remaining of 4 grams a kilogram. This means that on average, their systolic blood pressure will be increased by almost 4 to 5 millimeter mercury. So that this is a very important window for our study to focus on them and explore the potential strategy to reduce their future risk. And currently, we launched a very interesting study, which is called SLIMMER trial. The trial is short for Strategy for Weight Loss in Pregnancy Postpartum among women with cardiovascular risk exposure during pregnancy. And this study is currently ongoing. And we'll talk about future directions. And you know that the concept of cardiovascular kidney metabolic syndrome, I think, is a really important definition of our disease quantity. But because it's a continuity of multi-system disorder, but we have talked about many different patients have different risks, so that we believe the population-specific risk stratification is very important to identify who is at high risk and who is low risk. And during pregnancy, we think that the pregnant women who especially experience APO is a time window for our opportunity to stop the future risk. And in this rare area, we think that established women as a very important event for CKM pathogenesis and a risk identification is very important. And we also need to refine the CKM definition for the reproductive age patient. And also, in the current evidence for their study is limited, so that a longitudinal multi-generation study is required. Also, we think that the mechanism, especially I mentioned before, the RAS-related CKM in postpartum women is very important to explore potential therapeutic strategies. And this year, together with Professor Tang and Professor Yang in our hospital, we published the expert consensus, especially focusing on the comprehensive risk management of hypertensive disorder in patients who suffered from during pregnancy. And we summarized the 3-stage preconception during pregnancy and postpartum, and recommended 10 points for our clinician, and especially for the multidisciplinary physician team to work together to treat patients with such kind of disease. But we can see that the current evidence for our recommendation is low, so that more research is really needed to give the robust evidence support our consensus. And we believe that by breaking through a disciplinary boundary, especially building the preconception, pregnancy, and postpartum full cycle prevention in collaboration of we cardiologists, gynecologists, and endocrinologists together, we could, during this 3-stage, to design different advice and different management strategies. And further together, by using such kind of framework, we should be educate the patient to tell them who are at high risk, who are the low risk, and develop the responsible and effective treatment strategy. I think this approach may be useful for our primordial prevention of CKM and secondary and or even the first prevention of this very important and disease burden to our human. And this is my share of the recent progress in this area. And also, we will thank our collaboration from Guangdong and Shenzhen for the collaboration to make this talk possible. Thank you so much. Thank you.
So thank you, Professor Jiu, and congratulations for your trials. Yeah, it should be very important, for the management of the productive age women and the prevention of cardiovascular disease. For the sake of time, I don't think we have time for questions. Maybe only one question or comments.
Yeah, I think thank you, Dr. So for your very comprehensive lecture, especially focusing on the primordial prevention transgenerational, because the female they cradled the next generation. So just for the mechanistic pathway, you said RAS has got a big involvement. So, but when it comes to the treatment with RAS inhibitors, we have some concerns about treating hypertension even in childbearing age with RAS blockers because of the risk of teratogenicity and others even. So what do you think the way forward? We have how much of threshold we should have treating postpartum and breast lactating women with hypertensive disorders with RAS inhibitors? This ACE inhibitors, ARAs, and even mineralocorticoid receptor agonist.
Yeah.
Threshold we should have.
Yeah, it's a very important question and very interesting. So that I mentioned that there may be some dysfunction in the RAS system. Although I think that the RAS activation is important for treating hypertension, but our observation for during pregnancy found that for some patients, especially for the patient with preeclampsia, the RAS activation is not adequate. It's not adequate. So that even for this patient, because during pregnancy, our current recommendation for sodium restriction is no evidence during this period. So that I think the patient in this area at least be categorized by 2 categories. One may be beneficial from the RAS inhibition. Another maybe need to have inadequate activation of RAS system. So that I think the only way we should focus on the patient is to just really focusing what is the role of RAS during the pregnancy, and then develop future for postpartum therapeutic management. I think our attempt in this area is just a premature preliminary, but no current evidence. But an in-depth analysis of during pregnancy, I think, is very important. Thank you.
Thank you.
Okay, thank you. Shall we move to our next speaker?
Yeah, so we'll move on, and it's my great pleasure to introduce our next speaker, Professor Chamila Methananda. She is the Professor of Clinical Pharmacology at the University of Kelaniya, Sri Lanka, and being an internal medicine physician, she has a very good understanding and insight into how the people with cardiovascular disease, kidney disease, and also people who don't have, just have risk factors, how they can be managed, and she has a lot of experience. And on top of that, she has dedicated a lot of research into this area, and especially the research in Sri Lanka, where we have a lot of research constraint, but her research will help for us to develop this prevention in Sri Lanka. So she's going to, I think, present one of her research work mostly on this area. So let me invite Chamila to proceed with the presentation.
Thank you, Dr. Patiran, for that kind introduction. I will share my slides first. Right. Can you all see my slides?
Yes.
Right. First of all, I would like to thank the Asian Cardiovascular Research Seminar, all the team in this association for giving me this opportunity. So I'm going to talk about like slightly different, like what we have done in Sri Lanka. And I think, I mean, there is way forward. We can take it forward to study the cardiac, kidney and metabolic, all the risks in future. So I'm going to talk about improving cardiovascular risk prediction of South Asians using machine learning. So what we did in Sri Lanka. Right, I have nothing to declare. So as you all know, so there are no cardiovascular risk prediction models specific for Sri Lankans, and there is none developed with Sri Lankan data as well. So we use WHO cardiovascular risk charts developed for Southeast Asia region. But these are again developed for the whole of Southeast Asia region using modeling approach without using individual patient data. So these predictions might not be the best for Sri Lankans, because the main reason is, even though all these countries like Indonesia, Cambodia, Vietnam, Maldives, Sri Lanka, all are like grouped in one group, the health metrics, lifestyle, diet, socioeconomic background, everything is different. We actually then validated the WHO risk charts in Sri Lankans, and what we found was it is good at predicting, especially in men, and to predict low-risk people, but we found that it is less predictive in females as well as in high-risk people. Therefore, we published that in PLOS One, and then so we thought we will develop a cardiovascular risk prediction model specific for Sri Lankans using data of Sri Lankans, and then we embarked on validating the new model in Sri Lankans. So what we did was we first developed several risk prediction models. We used machine learning, so artificial intelligence, and we machine learned the data of a Sri Lankan cohort followed up for 10 years. Using so we developed several models, and we selected the best model by comparing with the ROC curves, and also looking at the availability of the variables that are used in the model, because being a developing country, we can't be using very expensive investigations. Then we validated the best model in an external hospital-based cohort in Sri Lanka. So the study cohort that we used was the Ragama Health Study Cohort. This is an ongoing prospective community-based cohort study. This was established in 2007 with help of Japan as well, as to study the prevalence of non-communicable diseases and risk factors and their epidemiology. So we this sample was selected by stratified random sampling of people between the age of 35 and 64 in 2007. And now still the study is ongoing. So we selected, so the baseline cohort, we selected 2,596 people who were between 40 to 65 years of age. The reason why we selected 40 is all the risk prediction models is predicting people above 40 years. And so all these patients did not have any prior cardiovascular diseases. Now, over 10 years of follow-up, these people developed 179 incident cardiovascular events, including cardiovascular deaths, non-fatal strokes and MI, and symptomatic like elective CABG and primary PCI in symptomatic patients. Now, using that RHS database, we used 80% of the data to develop our model, and then 20% of data to try the model as an internal validation. Now, once we we developed several models and we compared it with the WHO risk predictions as well, and then selected the best model. So the three models we did were, the first one, we used all the variables, and the second one, we used the most predictive 6 variables. So that the most predictive ones were age, sex, smoking status, systolic blood pressure, history of diabetes, and their LDL cholesterol level. Then we tried another model, the third model, using the same variables that are being used in the WHO risk chart. So they also came as the same variables, except there we use total cholesterol, because total cholesterol is freely available even in the periphery, but LDL cholesterol is not available in the periphery, especially in the government sector. So we compared these models and we selected the best model for use in primary care as SL-CVD score, Sri Lanka CVD score. This is the comparison of the 3 models and the WHO score. You can see the ROC curves, like the model 1, 2, 3, all 3 models, the new models that we developed, they had a very good area under the curve of 0.98, whereas the WHO risk charts had only 0.52. Now, we compared these models using different parameters, the precision, accuracy, F1 score, and the recall. So if you look at the accuracy of all 4 models were okay. That means the overall predictive ability was okay. However, the problem was in the precision. Precision is the prediction of high-risk individuals as high risk. So that was like the abilities of the WHO score in predicting high-risk patients was low. And then the recall is detecting all the high-risk patients as high risk. That was also low in the WHO score. So we selected the third model, the model 3, as the SLCVD score. That was the one that the same variables used by the WHO score, because the variables are easily available in the periphery, and all 3 models performed almost similarly, not without the major difference. So if I show you the ability to predict true positive events, the model 1, so there were 179 events. Of that, 173 were predicted by the first model, but there you used more than 25 variables, so that is not clinically plausible to use. But the model 2 and 3, they predicted 162 and 169 out of all the 106, the predict 179 events. So they were fairly good enough. But the WHO model was able to predict only 10 of the high risk. But I must say the WHO model was good to predict low risk people. So the problem was with predicting high risk people. So then we externally validated this score in a separate validation cohort. There we used hospital-based patients of 358 patients. There were 119 of these this cohort had cardiovascular events, and 239 did not have any cardiovascular events. So we tried the SACVD score and the WHO risk charts in this validation cohort, and this shows what we found. So our validation, the SACVD score, the new model had an area under the curve of 0.64, not so great as in the model in the cohort that we developed it, but it was much better compared to the WHO score that had only 0.54 area under the curve. And then looking at the number of high-risk patients predicted by the two scores. The SACVD score could predict 56 out of 118 cardiovascular events, whereas on the WHO score could predict only 18. So the new score could predict 38 more cases compared to the WHO risk charts. So based on now this risk model to be practically usable, so we developed a web-based platform, a calculator. So using that age, sex, diabetes prevalence, systolic blood pressure, cholesterol, and smoking, like Framingham score calculator, we with the collaboration of the Sri Lanka Institute of Information Technology, because they are the ones who gave the technological support for this. And then, so in conclusion, what I would like to say is so the SACVD score, which was developed using our own data by machine learning, is more effective in predicting cardiovascular risk, like the high-risk people in Sri Lanka, when compared to the WHO risk charts, which is developed for an epidemiological area for several countries. So this similar approach can be used by the other countries as well to risk predict their patients. And listening to all your talks, I think the next step that we can do is we can use the same to develop something like to risk predict the CKM risk in future as well. Thank you.
Yeah, thank you, Jamila, for very comprehensive talk about risk stratification. And if there are any questions from the audience, we can entertain few questions or comments. Yes, Jamila, what do you think this WHO risk score and your score more or less using the same basic parameters for risk stratification? Why do you think it's a difference, such a big difference in high risk prediction in local setting?
Yeah, I think so. The one good thing about that now what we also found is we also found the same risk factors are the ones that predict our risk. So that is another plus point to say what we are doing is correct, because now the WHO risk charts are developed with lot of evidence, and also we also found the same thing. But the difference that we see is this is for several countries, in Sri Lanka, those South Asia, there are lot of other countries do have low health metrics, but compared to that, even though we don't have good economic situation, but our education and the health sector is very much like good, like even in a
Yeah.
developed country, we have very good health metrics, or like the literacy rate and everything, like the health metrics are good. So that may be one reason, because the WHO, when they are like, I mean, using all the data, pool data and developing the risk prediction model, that may not be the exact for us. And the other thing is the WHO, like, I mean, so when they are developing it for a region, what they have used is like the not the individual patient's data. Like, I mean, so they have used like the prevalence of diabetes in Sri Lanka. So likewise,
Yeah.
not the individual patient data. Whereas here we have
Mm.
like actually followed up a cohort
Oh,
for 10 years, and we know exactly individually what happened to these patients. So it is more finer tuned for us. But
yeah.
I must say, like, the WHO score is good. Like, I mean, so like, I mean, even better than our one in sometimes predicting the low risk people. The problem was picking up the high risk people. And in our setting, like, I mean, in a country like developing country, we can't go for like a population-based strategy to implement cardiovascular risk prevention. Whereas we have to go for high risk strategy, because we don't have enough money to treat everybody with statins or check likewise. So going by a high risk strategy, picking up the high risk people exactly is what is more important. So that purpose is served by our RISCO. We actually have applied for patent rights as well. So once it is available, we plan to implement it through the Ministry of Health, so that anybody can easily use it even in the periphery, because we have now developed an online platform as well.
Thank you, Jamila, for that very good explanation and your work.
Just
Congratulations. Yeah.
one question. Can I ask one
Yes.
question?
Sure.
Yeah,
Yeah.
thank you very much. Actually, in high-income country, premature death due to cardiovascular disease is increasing. Mostly, the heart failure is an important event, and also cancer or other causes such as pneumonia will be the main cause of the mortality. So, but in your country, Sri Lanka, what is the most important event of cardiovascular disease? What is the end point of the prediction of risk factor? Is it myocardial infarction, stroke, or cerebral bleeding stroke? What is the most important event?
So in like, I mean, we have like looked at the incidence and prevalence of cardiovascular diseases in Sri Lanka in the same cohort over the 10 years as well, where we found like we are yet to publish it. We compared it with the global data, and what we found is our the myocardial infarction, the ischemic heart disease prevalence is almost similar to the Western countries. Right. Whereas, but it is actually lower than Southeast, other like the India, like other South Asian countries. But our stroke risk is very much low compared to the Western countries. That's what we see, like the stroke, ICH and ischemic stroke, both the risk is very much, the prevalence is less. So like the world, the prevalence of like when the ischemic heart disease is about like, I think it was 800 per 100,000 population. So our one is like 715 or so. But the stroke prevalence, stroke incidence is in the world is about like 150 per 100,000, whereas our one is like 65.
Okay.
So it's
Okay.
very much less.
Thank you very much.
Thank you. I think we'll move
Okay.
on. Yeah. So
Okay. So our last speaker is Professor Yihui Zhang from Fry Hospital, and Professor Zhang is the Director of Heart Failure Center and the Heart Failure Care Unit in Fry Hospital. And the topic today for Professor Zhang is about the CKM and heart failure. So please, Yihui.
Yeah, Thank you for the introduction of Yihong, and it's my great pleasure to join this session. And my speak is on the CKM and the heart failure. So this is my the main content. First is on the CKM heart failure, the overview and the mechanism, and the second part is on the treatment and evidence. So for the CKM syndrome is that there is a staging for the CKM syndrome. So for heart failure involved in stage 3, the CKM syndrome can cause the subclinical heart failure, and the stage 4 and the CKM can cause the obvious symptomatic heart failure. So the concept diagram and the complex mechanism between the CKM syndrome is such like the for the metabolism syndrome, it can cause the excessive dysfunction from the adipose issue, and through the main mechanisms such as inflammation and oxidative stress and insulin resistance and vascular dysfunction. For the heart, it can cause the atherosclerosis and myocardial remodeling and fibrosis, and at last cause the cardiac dysfunction. And for the kidney, it can cause the multiple sclerosis and the chronic kidney disease. So all of this have the interrelationship between the metabolism and heart and the kidney. And for the heart dysfunction, the main mechanism from the CKM is such as the molecular mechanism of HPAF, and also the developed in the HPAF. And so there is a very overlap and complex mechanism. So from the data of the clinical trial, that shows nearly from the 6 RCT data that shows for the HFrEF and MRF and PAF, the CKM percentage, such as the diabetes, is nearly 30%, and for the obesity is more percentage in the MRF and PAF, and for the CKD it's also nearly 30 to 40%. So how to treatment and what we get the evidence from the treatment. The CKM syndrome management, we should emphasize patient-centered implementation. So we can first for the lifestyle and also the pharmacotherapy, and we also to set up the concept of long-term management. So for the CKM, the evidence for recommended approaches for the treatment of CKM, it is for the stage 0 and to stage 4, and for the diabetes, so there is SGLT2 and GLP-1, and also some for the prevention for the future heart dysfunction or kidney dysfunction. So for the heart failure, so for the subclinical heart failure, in symptomatic LV dysfunction, the ACI beta blocker is associated with less heart failure or CVD mortality. And in diabetes, the SGLT2 inhibitor decrease the risk of incidence of heart failure. So for for the totally treatment evidence in recent years, just focused on the benefit from the MRA, such as the finerenone and SGLT2 inhibitor and GLP-1 rise antagonist have changed the therapy landscape for the CKM and also the heart and diabetes. So for the first drug is the SGLT2 inhibitor. So SGLT inhibitor also have multiple mechanism to improving the heart and also the CKD. And from the mechanism is very familiar with ours. So it can cause the multiple benefit for the heart failure and also the CKD. So the data in the DAPA and AMPA heart failure study also showed SGLT inhibitor can slow the rate of decline of eGFR and also improve the outcome of kidney outcome and including the heart failure outcome. And it is have the robust evidence for the all EF heart failure patients. So for the GLP-1, there is a close relationship with obesity and heart failure. And there is also some mechanism such as the inflammatory cardiac depression factors release, and which can cause the cardiac dysfunction. And the evidence for the GLP-1 also came from the kidney dysfunction and also the HFpEF. So in the FLOW study, this is the first study to explore the impact of semaglutide on renal outcome in patients with type 2 diabetes. And the result shows it can to improve the kidney outcome. And in the HFpEF study for the STEP and STEP-DM in HFpEF patients. So both of the study can show that semaglutide can significantly improve the clinical composite and also improve the 6-minute walk distance and also improve the KCCQ study. So the pool analysis for these two studies also shows the same result in obesity-related HFpEF patients. So in the SUMMIT study, it shows compared with the placebo and the tirzepatide can significantly reduce the risk of the composite endpoint of cardiovascular death or worsening heart failure. And this is a meta-analysis of the GLP-1 trials. It totally includes 11 trials and shows the overall result. It can show the GLP-1 can reduce the heart failure hospitalization. So next for the MRA. So the heart failure and chronic kidney disease, there is also involved this mechanism such as the inflammation, oxidative stress, and vascular or cardiac remodeling, and the endothelial dysfunction and the insulin resistance and hypertension also can involved, and the aldosterone excess and MRI overactivation are the key driver for cardiorenal pathological such as CKD and heart failure. So also there the MRI overactivation drive inflammatory fibrosis is one of the underlying pathophysiological mechanism leading to the cardiorenal injury. So totally the finerenone is recommended in the ADA guideline for heart and kidney risk reduction in patients with CKD and type 2 diabetes. So there is the trial such as the Fidelity and Fidelify code analysis. So for the Fidelify, so Fidelity, it shows the finerenone can significantly to the kidney and cardiovascular risk reduction in patients with CKD and type 2 diabetes, and also include the kidney composite and the CV composite, and also can reduction for the UACR. And the finerenone on the heart failure, it is the fine arts heart failure study, and the inclusion is the patients, the heart failure patients, with EF more than 40%, and also have the structure heart abnormalities within the last 12 months. And the primary endpoint is the CV death and total heart failure events. So the result shows finerenone demonstrated clinical meaningful 16% relative risk reduction in the composite of CV death and total heart failure events. And also in the fine arts heart failure also shows the finerenone can reduce the risk of new onset diabetes compared with the placebo in the MIRF and PAF patients. So the fine heart is a pooled analysis of the phase 3 trials on the heart failure and CKD, and the result and from the whole population is showed the 90% of patients enrolled in the fine heart had overlapping the CKM conditions, such as the 3 CKM conditions is 12%, and the 2 CKM conditions nearly 80%. So the result shows the finerenone was associated with a significant reduction in CV deaths when including the entertainment deaths, and also the effect of finerenone on the primary endpoint of CV deaths were consistently regardless of comorbidities and CKM burden, and also shows the effect of finerenone on the primary endpoint of CV deaths were broadly consistent regardless of baseline use of medicine, such as the GLP-1 or SGLT2 inhibitor subgroup study shows the nearly the same trend. And also the finerenone demonstrated significantly benefit in prospecified CV and kidney endpoint compared with placebo. Also the totally heart failure risk rehospitalization, and also the kidney composite endpoint, and also the CV death and totally heart failure rehospitalization. And we also showed, we also see the result, it can reduce the new onset atrial fibrillation. So we can get the recommendation in the guideline such as the AHA CKM statement. It make the recommendation for the CKM stage 2 and CKM stage 4 CKD and CVD. The phenomenon shows the for diabetic patients with CKD with the EGF more than 25, it can reduce the adverse renal and CVD events. And in the 2025 guideline of AHA CKM also make the recommendation for the use of patients with type 2 diabetes complicated with CKD to reduce the risk of rehospitalization for heart failure. And also in Japan, a guideline for the heart failure that just published in recently, and also make the similar recommendation. So for the CKM and heart failure, there is 4 pillars for the treatment. One is the ARAS inhibitor and the MRA, especially for the non-steroid MRA, especially for the finerenone, and the acetylcholine inhibitor and the GLP-1 receptor agonist. So we can also to pay attention to each drug's side effect when they put together for the treatment of CKM. So I think in the future it is very very important to set up the flowchart and to set up the concept for the long term of management of CKM. Thank you so much.
Thank you, Professor Zhang. So it's a very comprehensive review of the treatment and also the risk factors control for the heart failure. And I think there's some emerging strategies. I mean, the medications, SGLT2 inhibitor and MRA, the finerenone, and also GLP-1 has also have some evidence in patients with HFpEF. So, a very quick question about, so was any new strategies for the treatment with patients with CKM and heart failure besides these 3 types of medications?
Yeah, thank you so much. I think in the future, the inflammation pathway maybe to have some effect on the treatment of the CKM because there is some study on the IL-6 or the reduction of CRP that shows some benefit effect both on the heart failure and for the CKD. And some results already have not been come out, but the trial such as the Hermes and other study now is ongoing. So I think in the future we can get more evidence for the system inflammatory pathway in the treatment of CKD. Yeah.
Okay, thank you. Any other questions or comments?
Yeah, can I have a comment? Just I'd like to make a comment. 4 pillar SGLT2 inhibitors and MRA are definitely important to protect the heart and kidney. And also on the left side, there was a description of ACE inhibitor ARB, but I could not see the ARNI, sacubitril valsartan. How do you think about the sacubitril valsartan compared with the ARB or ACE inhibitor to protect the heart and kidney? And also about the GLP-1 receptor agonist, do you think it's okay to use for patients without obesity to reduce the risk of heart failure, just in patients with diabetes, without the risk of without obesity to reduce the risk of heart failure? Two questions. Yes.
Thank you so much. I think because the time is so limited, so I do not include the RNA on the treatment of CKM, but the result is very limited. So there is analysis from the paradigm study that the RNA can also to protect the decline in eGFR from the baseline, and also for the Paragon study combined with the paradigm study that also showed some data that the RNA can sustain decrease the eGFR more than 50% of ESKD and renal death. And for the GLP-1 for the treatment of patients without obesity, I think if the patients have the high risk of ASCVD and also have the maybe it can be used for the prevention of the future CMIS outcome. And also I think in the future we can initiate some study for the GLP-1 for the different kinds of obesity patients, such as the central obesity patients, especially in our Asian population.
Thank you very much.
So if no further questions, and Professor Koshi-Hasegawa, please give our closing remarks.
Thank you very much. It was a very excellent 4 lectures, and also very active discussion, which I believe very informative and useful for clinicians. Maybe the listeners participate in this symposium will change their clinical practice maybe from tomorrow. So I believe it was very useful seminar. Thank you very much for joining. Thank you very much for excellent lectures, all the speakers and all the chairperson, all the listeners. And thank you very much, and see you in Beijing next October. Thank you very much.
Yeah, thank you. I think we have another symposium in 2 hours time on lipid and the protein abnormalities. Yeah, we up there again online. Yeah, thank you.
Okay, thank you very much.
Thank you. Thank you.
Bye-bye.
Bye.
Bye.